Dr. Childers to introduce our next speaker, who probably needs no introduction.
Many of you already know Dr. Naqvi, who is Consultant Paediatric Cardiologist at the Royal Brompton Hospital and an internationally acclaimed expert in management of heart disease in children. Beloved by her patients and their parents and supported by knowledgeable staff, Dr. Naqvi is creative and innovative in dealing with problems. She kindly volunteered to be one of our charity's trustees, and we are very happy to have her also on our advisory committee. Nitha will explain the latest thinking in her field. Thank you, Nitha.
Hi, thank you for that lovely introduction, Anne. Everybody knows that Anne is my absolute greatest hero on the planet. Honestly, one of the most incredible human beings that I've been blessed to meet in my life. So it's so lovely to be introduced by her. Fortunately, I've got my daughter Sophia, who's a medical student, here with me, helping me to try and show the slides, because I've got lots of skills, but working with Zoom is not one of the best ones that I have. We tend to use Teams in the hospital setting. So can you let me know if you can see my slides?
We can see that.
Oh, wow. Well done, Sophia. Thank you very much. I am going to talk about aortopathy in children, and I very much enjoyed the previous talk. So now, Sophia, how do I move the slides along?
Just press the arrow keys at the bottom.
Oh yes, okay. So great, so it's working. So this is me with some of my patients at the Royal Brompton Hospital, where I've worked for a long time. I chose paediatric cardiology because I think it's like the very best job in the world, and I'm so lucky to work with the most fantastic patients. I trained at all these places, so I don't know if you recognize some of them. There's Guy's Tower. They have a competition every year where everybody runs to the top, which I think is the 35th floor. My children have done that, and it's my aim one day in my life to try and get up there without the lift. I've worked at Great Ormond Street. Then bottom left is St Thomas's Hospital, which is also where I trained as a medical student. And we've got Birmingham Children's Hospital as well, which is a fantastic institution. I remember when I was working there, the Queen was going to come. And one of my biggest memories is that they built a brand new toilet because she was coming. I didn't realize she always goes to a brand new toilet. So you're learning lots of different information from me today. Oh, and there's Northwick Park as well, which I've loved. My greatest achievement is that I won Asian Woman of the Year. And this is my favorite place, the Royal Brompton Hospital, which was built in 1840. So at the Royal Brompton Hospital, we look after patients from, we used to say the cradle to the grave, but now it's even before then, because at the top left, you'll see I've got a picture of an ultrasound in the womb, and we are actually able to even look at babies' aortas in the womb. One of my colleagues, Professor Jelani Carvalho, is an expert in fetal aortopathy. So that's this, when we sometimes notice that the aorta is enlarged even before the baby is born. And she has created Z-scores to actually look at measurements of the aorta and normal ranges in babies before they're born. Then we, being a hospital that looks after from babies to old age, we're able to look after babies, we're able to look after patients for their whole life, and we do our best to give a family service. So these are some of the things that we try and do in our Marfan service. So on the left here, I'm not sure if you can see my arrow. These are our aortopathy nurses. We're delighted that now we have a full-time pediatric aortopathy nurse, and the aortopathy nurses really do a lot to support families, and they do their best to answer queries on the phone and via email, and they also run our transition service. So the government has now said that if you have a chronic condition, you should be provided with transition service from the age of 12. Transition service actually means when the child is changing from being a child to an adult and should be learning to take more responsibility of their condition. Because one of the things we found in all types of conditions that children can get, once they become teenagers, they often rebel, which is a totally normal thing to do as a teenager, and compliance with medication and treatment tends to fall. And when they leave home, either to go out to get a job or apprenticeship or go to university, they often drop out of medical care and don't reappear sometimes for decades, and that's a detriment to their health. So because of that, the government has been reducing the age of transition. So it started initially being age 15, and now it's fallen to age 12, and that's something that the Royal College of Paediatrics and Child Health works on. So it's not just for Marfan, it's for like many conditions, like for example, cystic fibrosis is a lifelong condition. The nurses lead the transition service. They initially start gently introducing a lot about the condition to the child, and they talk about matters that are very important that doctors tend to sometimes not talk about so much, but things that are very relevant to children, like taking drugs, smoking, vaping, safe sex, these type of things, and things that are very important, as well as medication. On the left here, we have Fortunate. She is the adult aortopathy nurse who supports families and also links in with the pediatric services. So she's also looking after the teenagers as well. Last week, we had our London Aorta meeting, which is a meeting that we run at the Royal College of Physicians in Regent's Park, where we make sure that as experts looking after people with aortic disease around the country and around the world, we meet. We are specifically talking about diseases of the aorta, Marfan's, Loeys-Dietz, and also other conditions that can cause aortic dissection. And we're really pleased that in the last 2 years, we've set up now a network of aortopathy nurses so that they're quite a new group, the aortopathy nurses, and some of you may not have an aortopathy nurse yet, but we're working on it. It took me like many years to get funding and to convince managers to get a nurse, and we're working to try and get them all around the country and to recruit good people. And we are blessed that because the patient groups who are affected by aortopathy are just such wonderful groups of patients, that we've got really high standard nurses competing for these jobs, which is great. This here is our emergency aortic dissection protocol, guideline for patients who are children. We sadly know that if you are a child and you present with an aortic dissection, your chance of getting to surgery and survival is minuscule compared to an adult. And that doesn't really make sense, does it? But the reason for that is that because it's so rare in children, when you present to the A&E department, it's much less likely that anybody will think of aortic dissection. And it certainly is extremely rare. I was talking to my colleague at Great Ormond Street at the London Aorta meeting, and we think that in the last 4 years in the entire London region, which is a huge region, we've had about 6 aortic dissections in children, and unfortunately none of them have survived, and they've all been people who did not know that they had an underlying genetic condition. They did not know that they had either Marfan or Loeys-Dietz. And then when they come to A&E with chest pain, the doctors are not thinking about it. So we're trying very, very hard to spread that message, and we have an emergency pathway. In adult A&E, people think of it a lot, but in children, they don't. And one of the reasons for that is chest pain in children is incredibly common, incredibly common. I will probably see at least 20 cases a week of a child with chest pain, and of them having an actual serious cardiac problem, there will be probably maybe about 3 a year. The rest are all just musculoskeletal growing type pain. So that's one of the issues. And the Marfan Trust is doing a great job spreading awareness about Marfan syndrome and other connective tissue disorders. We know that we're looking for 15,000 people in the UK who have Marfan syndrome but are not aware of it. And meetings like this are all trying to spread information about that. At the top here, we have one of my amazing patients who was really quite unwell as a baby and is an inspiration, and has the most severe form of Marfan syndrome, which is called neonatal Marfan syndrome, which is also associated with a lot of lung problems as well as cardiac problems. And she has been on the BBC, she's met lots of celebrities and done lots of fundraising for the Marfan Trust. This is our Marfan Matters magazine, which is produced by Victoria and our mainly Victoria, I think, and our brilliant team at the Marfan Trust, spreading information. We try and do an annual transition day for teenagers with Marfan syndrome at my institution, where we take them to Chelsea Football Club and they get to meet other people with Marfan syndrome. And it's so great to meet outside the hospital, because we really don't want people thinking about their condition, especially when they're young, as something that is always a negative thing. And often they haven't met anybody before with Marfan syndrome, and we provide education on that day, but also it's a very positive day, and we are always keen to have people with different connective tissue disorders who are older in life to show all that they've achieved, because of course so many people achieve exactly what everybody else is achieving. So currently we're saying that lifespan with Marfan syndrome is to the 70s. That's on average. And also with other connective tissue disorders, we now have more information about lifespan. Probably a baby born today, we might be thinking without any genetic condition will be living to about 110 years. So that's what we're working on. And I do think that a baby born today or in the last few years with a connective tissue disorder, the outlook is so much better, because now we are so proactive. And previously it was mainly, apologies, if you had a diagnosis of some kind of connective tissue disorder, you were watched. It was often diagnosed when the aorta was already enlarged, and then treatment was mainly surgical. But now, of course, it's very different. We are very proactive. We are trying to give treatments as early as possible to try and prevent aortic problems occurring. And if they are occurring, we're trying to push them back by at least a decade. That's our aim. So that if in the past somebody might have needed surgery as a teenager or in the early 20s, if we can push that back by a decade, then they will have led much more of their life before surgery. And we know that the earlier you are when you have surgery, the earlier you are more likely to have another intervention later in your life. So that's one of the things as paediatric cardiologists we're really working on, to try and delay any need for treatment. I mean, ideally, the eventual goal is that we hope that people wouldn't even need any surgical treatment, but we are, to say that we're at that stage is not true yet, but that's what we are aiming for. So coming back to talk about the heart, to simplify things, although I think everybody on this call is really quite expert already, I always think of the heart as Naqvi's rule of 4. We've got 4 chambers, 4 valves and 4 big vessels. So I'm not sure if you're able to see this video here, but it's showing the blue blood coming from the upper body and the lower body to the upper chamber, the right atrium. Then it goes to the lower chamber, the right ventricle. Then it's taken to the lungs with this big vessel here, the pulmonary artery. The lungs give the blood oxygen, and the blood comes back through these pulmonary veins, which again, there's 4 pulmonary veins, to the left atrium, the upper chamber, then to the left ventricle, and then goes around the body through the aorta, which is the blood vessel that we are most interested in connective tissue disorders. And here on the picture as well, we can see here is the aorta. This is the mitral valve, which is the most important other valve that we're interested in, particularly with Marfan syndrome. So these are beautiful pictures of the heart given to me by my colleague Andrew Cook from the Institute of Child Health. So here we can see the echocardiogram view, and now you can see very clearly the right atrium, the tricuspid valve, the right ventricle, the left atrium, the mitral valve, and the left ventricle, and this is a papillary muscle here. When we look at the 3D generated version, we can see how incredible the heart is. It beats so many times in our lifetime, and it never ever rests. We can see here the mitral valve, and we see all the cords here. And the valve, when you look at it, it is actually very thin tissue. And in connective tissue disorder, unfortunately, the tissue is even thinner than normal and even more friable, which shows you how amazing our cardiac surgeons are to operate in this very difficult environment. And certainly I would say that connective tissue surgeons, aortic surgeons and mitral surgeons are really the top surgeons in the world. This is looking now at the heart, what we call en face, as if we've cut the heart in half. And this is the mitral valve here. It looks a bit like a fish mouth. It also looks to me like one of those very scary triffid, were they called triffid flowers? I remember reading about them when I was a kid and being very frightened that they would come and eat me. It looks a bit like that, but you can see how delicate the cords are, the strings, and so this is the mitral valve, which has here, it has, you can see, I'm not sure if you can see my arrow, but it has 2 leaflets, whereas on this side, this is the right ventricle. It's a slightly different shape to the left ventricle. Can you see the right ventricle? We call it more banana shaped, and it's wrapping around the left ventricle, which is more circular shaped. So the tricuspid valve has 3 leaflets, whereas the mitral valve has 2. And these are the things we are looking at when we bring you to the clinic and we look at the echocardiogram, because we're very interested to see if any of these valves are leaking. So in children in our clinics, we are looking at patients with, the commonest is Marfan syndrome, but obviously we have Loeys-Dietz syndrome, which we are learning much more about, and it's fantastic. I feel happy when I get sent a child with Loeys-Dietz syndrome, not happy in that obviously it's a huge difficulty when you look at it, obviously, and so distressing for families. But from my point of view, if we can find these patients when they're children, we know that their outlook for the future is going to be so much better, because we're going to be able to treat them early and be proactive. Ehlers-Danios vascular type 4 is another connective tissue disorder, which is probably, of all of them, probably the most severe form, and children who have Ehlers-Danios vascular type 4, we try and get them cared for in a unit where we have lots of disciplines available, so the doctors are working together, because it's not just the cardiac system that is affected. And although I am not the best at computers, we are actually finally moving forward as the NHS in that our computers are improving so that we can now share notes. I had my aortopathy clinic yesterday afternoon, and I had a patient who had been to 3 different hospitals, which is very unfortunate, but all of you as patients know that that often happens, that you get sent here and sent there. But for the first time, I was able to see the notes from all the different hospitals, and the family were so pleased that they were very organized. They'd actually brought them all in a file, and I know many of you are having to do that, because otherwise when you come and see doctors, they can't get all the information. But that is something positive, that we are finally seeming to make some progress with that with the NHS. Familial thoracic ascending aortic aneurysm and dissection is a condition that really isn't affecting children, in that we're not getting children with that condition having aortic dissection, but they may be carrying the gene, and maybe sadly that an older person has passed away and they might be a parent, and then because of that reason the children are sent to us, and then we can look at the genetics in our aortopathy clinic. For children, nearly always we have a geneticist present, so that then we can best of all find that they don't carry the gene, and be able to reassure them and send them on their way. And if they do carry the gene, then we can be watching them to ensure that they have a good outlook and they don't have a dissection later in their life. Turner syndrome, I don't think we probably have people on this meeting with that, but Turner syndrome is a condition where which affects nearly always girls, but sometimes mosaic boys, where they tend to be very short, and they have, again, abnormalities of the aorta, and they get dilated aortas. Bicuspid aortic valve, the previous speaker talked about, which is a condition where the aortic valve only has 2 leaflets instead of 3, and that can be associated with the aortic dilation and leading on to problems. And also, we can also have people who have bicuspid aortic valve, which is about 2% of the population, who also do have Marfan syndrome or Loeys-Dietz syndrome or another connective tissue disorder. And then also in our clinic, sometimes we see people with congenital heart disease, which is the type of problem where you're born with perhaps a big hole in your heart, or some of the tubes connected the wrong way, and they can also get dilated aortas as well. So these are the patients that we're seeing. Victoria, you'll have to keep an eye on the time for me, because sorry, I can't see that. So if you could give me a warning when I'm running out of time. I've got a question here for everybody, which is, if you have a newborn baby where there's a family history of Marfan syndrome, for example, maybe the mother or the father has Marfan syndrome or Loeys-Dietz syndrome, how worried should you be? So I've said A is very, B is not at all, and C is a little bit. So I don't know if anybody's got an answer for that. I get lots and lots of calls like this, that the baby's just been born and the family are so worried and they want me to see the baby that day. And I always say there is nothing to worry about at all. We don't have babies who inherit connective tissue disorders who get into trouble as a baby. We have that condition, neonatal Marfan syndrome, which is a severe condition which can affect babies, but that is not inherited. That's always a new mutation. So actually, I always say, please don't worry. Please enjoy the experience of having a baby. And we try and see the baby within the first 6 months of life. What we try to do is do genetics, because we'll always, if it's a condition in the family, we should already have the genetics of the parent who's affected, or it might there might also be a grandma and uncles and aunts who are also affected. And if we can then do the genetic screening, then if it's negative, and with Marfan syndrome, there's a 50% chance the child will not be affected, then we can then discharge the child and we don't have to worry at all. So nowadays, we also are offering amniocentesis, so we can do the genetic test earlier in pregnancy, so that the parent may know even before the child is born. It's very reassuring if your child doesn't have it, but of course, if your child does have it, then it means you can be more proactive. In my experience, most families turn that down because of the small risk of miscarriage associated with amniocentesis, and that, of course, I do totally understand that somebody may not want to take that risk. I've got a picture here about aortopathy, showing the bits of the aorta which enlarge. So in children, as in teenagers, the thing that we always talk about is the aortic root. So the aortic root here is just the area just above the aortic valve. Here we can see our Mercedes-Benz aortic valve. Here in the normal patient, we see that the aorta is not enlarged. And here you can see this area here, which we call the root, which is, as doctors, we sometimes also call the aortic sinus, is the area which tends to enlarge first. Later in life, if you have connective tissue disorder, other areas of the aorta can enlarge, the ascending aorta and other areas, even the descending aorta much later in life, which is the area coming down to the tummy. But in children and teenagers and young people, this is the area we are looking at first. And that's what we will be measuring in the clinic. This is an echocardiogram. So this is looking at the heart from the side. So this is the aorta in a normal person. So this is the valve, this white area here, and then this is the tube coming up the aorta on its side. So this would be a normal sized aorta. And here, this is one of my patients with Marfan syndrome, and you can see straight away how much enlarged it is. So this is what we call the root, the sinus. It looks a bit almost like a spring onion. In that it's very enlarged here, whereas here it's small and here it's enlarged. So these are the measurements that we are taking when we do echocardiograms. If you've got a child that you're bringing for an echo, if at all possible, it's really great if they're a little bit older, if you can try and prepare them, because sometimes they get very, very frightened and they don't they don't want to lie there for the scan. And the hardest age for us tends to be around the toddler age, where they really don't want to lie. I've just bought myself this toy called a Tony's, which I bought for £150, which is a musical box, which I've got to try and help distract the children for a little while. I always do say, if you're bringing a smaller child, please do bring, if they have a dummy, please bring some milk for them. Please anticipate that the wait in the clinic might be quite long, which we really apologize for. But with children, we do try and do everything in one day. So we try and do the ECG and the echocardiogram and seeing the doctor all in the same day, and weighing them and measuring them and doing the blood pressure. And these things as adults we get much more used to, but for the children, even just having the blood pressure taken is often very frightening for them and very painful for them. On my website, I actually have a video of myself doing an echo on a child, and I try and get my patients to look at that before they come. And then we have a child doing an echo on a cuddly toy lion with just a tube of toothpaste and some cream, just to try and get the child to be aware of what's going to happen. One of the things that children get most upset about, in my experience, when they come to clinic is the stickers and having the stickers peeled off. And as adults, you'll know that sometimes that is a bit painful. And my knack that I tend to do, that I would advise you, if the doctors and the nurses and technicians are not doing, is to pat the patient. So if you, to not pat the child. So if you pat them, I normally say, oh, I'm going to make you like a drum, and I pat them. And when you pat them and you pull the sticker off, the brain gets a little bit confused with this thing called the gate hypothesis, and it only feels the patting and it doesn't feel the pain of the sticker being pulled off. So that's a hint to you if you have a child who gets scared coming for the test, because the ECG, obviously we have a lot, usually 14 stickers on the child, and then for the echo we have 3. Here I've got a picture of mitral valve prolapse. So this is a normal mitral valve. Now I've shown you some pictures of the heart. This is the left atrium and the left ventricle, and we see the normal strings there, the cords. With mitral valve prolapse, which tends to occur in Marfan syndrome, the valve leaflets tend to be at a higher level. So you can see here they're at a higher level. They're actually inside the upper chamber in the left atrium rather than at the valve level. And the area where the valve is closing is above the normal level. So the normal level is here. This is the annulus, but it's actually closing higher up. And that's what we call mitral valve prolapse. And that tends to be associated with the valve leaking. If we have a child with a mitral valve leaking, it tends to be really very well tolerated. And we would not plan to operate on it unless it was severe. It's quite surprising that we have children with really quite severe leaks and they're running around normally. And as I said before, we try and delay any operation as long as possible, because we know once we do one operation in your life, you're more likely to need another one later on. And we're trying to move everything back as much as we can in the lifetime of the patient, as we are hoping to have our patients living to 100 or beyond. So if we have a child with mitral valve regurgitation, we would normally be watching it, and then if it becomes moderate, we would be starting drug treatment. All our medicines we have as liquids as well for children, so we can start medication as soon as we need to. This here, I've got a question: what is a PEC? I don't know if any of you know what a PEC is. So pecs are the pectoral muscles, aren't they? But a PEC is a name for a pediatrician with expertise in cardiology. So in the past, we had children being always looked after by the pediatric cardiologist if they have a connective tissue disorder, and all the appointments were at the cardiac center, which was often very, very far away. We actually only have 12 cardiac centers in the whole of the United Kingdom. So that means that people may well be traveling 2-3 hours. I had patients coming to see me yesterday to London from Dorset, from far away. So in order to try and improve that situation, we now have pediatric consultants who are in each district general hospital who are trained in cardiology, not to the same expertise as a pediatric cardiologist, but they can do echocardiograms, which has been a really amazing change for patients. And therefore we can do some shared care. And also it means that if anybody is taken to the local hospital, if they're unwell, there is somebody hopefully there who can perform an echocardiogram. You don't have to wait for an ambulance to take you to the cardiac center, which might be far away. So if you have a child with a connective tissue disorder, you do need somebody who is coordinating the care, because you're unfortunately going to need, if you have, for example, Marfan syndrome, to see an ophthalmologist for the eyes. You're going to maybe need to see an orthopedic surgeon for the back, or there may be PEC hiatus as well, which may be a problem, or problems with the other joints. Then you also have your cardiologist. If you have Loeys-Dietz syndrome, there may also be gastrointestinal issues. So often it's down to the parents who are coordinating things, and it's a real struggle for them. I do my best to try and coordinate for my patients, but if you can find a pediatrician who can coordinate, that is really excellent, especially as if your child has a connective tissue disorder, it doesn't mean they're not going to have all the normal problems that children get. Headaches are incredibly common in all children. Tummy ache is incredibly common in all children, as is chest pain. And when your child has a connective tissue disorder, obviously the main fear is, oh gosh, is it something extremely serious? But it may also be the common things. Constipation is common in all children as well. So if you can have a pediatrician, that is great. And I would say to you, if you see a pediatrician, what may happen to you is they say to you, oh, well, you're being seen at the cardiac center, so you don't need to see us anymore, and they discharge you off the books. And if that happens, I would advise you to try and put in a plea and say, oh, well, could you just see me every so often so that I stay on your books? And then if there is a problem that is not cardiac related, or that is, then you could help me with that. There is pressure for all doctors to be discharging patients, but I do find that if you have got a good pediatrician, it really does help. Often those of you who are adults on the call will say how you're struggling, that you don't have one person coordinating things for you. And it is so very difficult, but pediatricians are very good at that. So I would try and ask you always to advocate for yourself, and do try and keep a pediatrician for you if you can. Marfan syndrome we all know about. It's rare, with a prevalence of 7 to 17 per 100,000. We all know it's the fibrillin 1 mutation, and it's chromosome 15q21. It's autosomal dominant, which means that if you if there's a parent with it, the chance of the child getting it is 50%. That said, 25% of cases of Marfan syndrome, and Anne will have to tell me, but I imagine with Loeys-Dietz it may well be a similar number, are new mutations. They are sporadic. They are the first person in the family with the condition. That is obviously always very difficult for families because they don't have the knowledge and the experience of the condition, and it is more challenging for families in that situation. And I'm always so grateful for families who have it in their family, who do offer support to families who are newly affected with, for the first time, a child with Marfan syndrome. And the Marfan Trust does a really great job in trying to put people together and give that type of support. We do know that if the first person in the family to develop Marfan syndrome is a boy, they are more likely to have a more severe course, in that they are more likely to need an operation as a teenager. But I do also have some girls who are the first who are affected in the family who've also needed an operation as a teenager. These are different famous people who've been who have been affected with connective tissue disorder. We don't know exactly which ones they've had. We can hypothesize. This is meant to be Mary Queen of Scots, and this is Tutankhamun. And we have famous musicians who've had long fingers, long slim fingers, who've then been even more expert at playing the violin or playing the piano. We know that Marfan syndrome is multi-system. Lots of different parts of the body can be affected. One of the challenges I've found in my experience is that we do have people with connective tissue disorder, including Marfan syndrome, who look entirely They don't have the chest wall issue. Sometimes the chest wall issue develops later in life. Actually, I've found that sometimes it develops as a teenager, but sometimes they may not have it and they may look entirely normal. And those are the people that we worry about the most, because those are the ones that people don't think of the diagnosis. Therefore, they never get an echocardiogram, and therefore they can get into trouble. If I also tend to find that if the person looks totally normal, it's also often harder to accept that you have an issue, and especially when you're young and being a teenager, we all know being a teenager now is much more difficult than being a teenager decades ago, because of all the pressure that they're under. They've been through the pandemic, social media challenges. So it is important, and I think we do need to really get that out as the Marfan Trust as well, that you can look entirely normal and still have a connective tissue disorder, and it still is very important to comply with any medication or anything that any expert has to try and offer to try and help prevent you needing surgery later on, or at least to try and delay it. But it is often really very, very difficult to accept, which we can all kind of understand. If you look entirely normal and then you've just got a doctor telling you your scan is not normal, but you feel fine, it is really very hard time. And we at the Brompton, we try and offer psychology support. Psychology support is really difficult for everybody to get all around the country, but we do try our best to try and offer it to patients, to children who are struggling with being given a diagnosis, especially as it's a lifelong diagnosis. In the clinic, we can easily check the arm span. We know that people with Marfan syndrome often have a longer arm span and it exceeds their height. Other quick things that we can do in the clinic is to see if they've got long fingers and thumbs, and you can see in this picture here the thumb is sticking out. Patients often wonder what we're doing, but these are clues. But as I said, you don't have to have these. You don't have to have a very slim arm where your finger and thumb can overlap. But if you do, that may be a clue that you may have a connective tissue disorder. That said, I have patients who have an underlying connective tissue disorder who are short. I have patients with Marfan syndrome who are chubby like I am, and you don't have to always be very slim, even as a child, to have the diagnosis. Often people have very, very flexible joints. If they have connective tissue disorder, they may have easy bruising and very thin translucent skin where you can see the veins easily. This is harder often in ethnic minorities because that clue is often not easily seen. I wanted to quickly mention medication. Have I got time, Victoria?
And I think so. I mean, this is a fascinating talk.
Well, anybody needs to go off for lunch or go to the loo, I don't mind at all, and we're recording, I think, anyway. Are we
3 more minutes.
Okay, so talking about medication. So people tend to worry such a lot about giving their children medication. And I really do want to be reassuring about this. We've got our big studies now. We've got guidelines that came out in the last few months from the American Heart Association and also from the European group, all talking about giving medication to children with connective tissue disorders to try and slow down aortic growth or ideally prevent aortic growth. What I often find is that parents fall into one of two groups that either want their children to start medication as soon as they're born because they really they've read the evidence and they understand it, and they really don't want their child to have to go through an operation that maybe they have been through. Maybe they may have even been through an aortic dissection. So they really want medication to be started as soon as possible, and we can even start it as soon as the baby is born if we know the diagnosis. That said, I have another group of families where they really don't want to give their children any medication, and they worry about giving medication. They worry about giving medication in the long term, and they say that they were not given medication. And so why is their child being given medication? Because they weren't given medication when they were a child. And I do totally understand these two different schools of thought, and neither of them are wrong per se. What I try and say is to remind everybody that your children are living in a different time to the time that you were living in. And we have huge advantages now with medicine that we can try and make things better for the future. And although you won't have been given a medicine because we didn't know about the advantages of these medications when you were a child, that doesn't mean that it's a bad thing to give it to your child. And as doctors, who are looking after people with connective tissue disorders, we are agreed around the world that we have evidence and studies on children that these medications do have a beneficial effect. We do know that medicines can have side effects, but in my experience, the side effects tend to be unusual. And if side effects do occur, it tends to be mainly dizziness. I always advise the children to take the medication before they go to sleep. So if their blood pressure is a bit lower, they're asleep anyway. But if they are getting side effects, then please do always let us know, and then we can reduce the dose, because we're trying to do personalized medicine, and the right dose of medication is different for everybody. So we don't have to be giving the very highest dose to be making people feel faint and dizzy. We can give lower doses, and we would rather do that than give no medicine at all. And I try and say, you know, everybody has a mobile phone today, everybody has a computer today. Generations ago, we didn't have those things. So it's a different time your children are in. So we don't need to be saying that we need to be doing the same type of treatment. Dissection symptoms in children will be exactly the same as adults. In my experience, if your child is known to have a diagnosis of aortopathy and are under care with a team and are under treatment, the likelihood of aortic dissection is extremely low. I haven't had any patients in my care as a child who've had an aortic dissection. As I said, children who have aortic dissections, it's usually that they have not been diagnosed beforehand. But of course, it can occur, and you do need to fight for your child to always have a CT scan when they go to hospital. It really needs to ideally be a gated CT scan. I find that doing a CT scan for a child is a really important thing to do, even though I am like 99% sure they're not having an aortic dissection. The reason I feel it's an important thing is those of you who are older and on the call know that getting pains all over your body is not unusual if you have a connective tissue disorder. And for children, the first time you get chest pain, it's really difficult to know, are you having an aortic dissection or are you having normal growing pains? And it's nearly always going to be normal growing pains. But having the CT scan that is very helpful for me as a cardiologist, number one, it gives me beautiful dimensions, and it's more accurate than a echocardiogram. Secondly, it's an education process for the child themselves to know, okay, now I know this pain that I had is normal growing pains, and having a dissection is going to be something different. And the next time I have this type of pain, which for sure they are definitely going to get again because they're going to keep growing, is not aortic dissection. And I always try and push for the scan to be done as soon as possible when they come to hospital, because what tends to happen is patients are in hospital for days while people are thinking, oh, well, I don't think they're probably having an aortic dissection, but they are getting chest pain, and they're probably just getting normal growing pains. And being in hospital, as we all know, is awful. So if we can do the CT scan as soon as possible, we can then exclude everything, and then you can go home and have normal types of painkillers. Like I said, dissection in children is very rare, but we do say do a CT scan. This is just a picture, different pictures of aortic dissections. In children, it's normally this area of the aorta that dissects. Later in life, it can be anywhere in the aorta. This is like a picture here, a diagram showing an aortic dissection. This is the aortic valve, and this is the aorta, and we can see the tear. This is looking at on FAST, and this is looking at the CT, and we can see, all of you, I think, can see there's a line there. So it's not difficult to diagnose the dissection per se. This is a normal CT scan. This is the aorta here, looking normal. Here's somebody with a dissection. So that's something I do want all patients to ask for if they are concerned that they're having severe chest pain. This is a picture again of the aorta, the arch, and again we can see the dissection, and we don't see the line in the normal person. So all hospitals have the facility to do CT scans. Then I just wanted to say about the medicines we give. We are giving beta blockers, which we can give as liquid. We're also giving children losartan and irbesartan. There are some people who are incredibly lucky and have a pharmacist who's able to get them a liquid form of losartan. I can't even get it in my own hospital, but there are some families who've been able to get it, and that's fantastic. We are working now on trying to get tablets which are so small that they dissolve on the tongue, and they are about half the size of a grain of rice. I am put at the moment they are making that for drugs that are called ACE inhibitors, which we use for the leaking mitral valve. I'm trying to lobby the companies to try and think of making that for losartan and irbesartan, because then that will mean we can give smaller children the drug, and we can give the benefits of that to younger children. And there are also some people who struggle with tablets. So if you can have a tiny one, half a grain of rice that dissolves on your tongue, that will be amazing. Of course, the companies are not so keen at the moment because connective tissue disorder is not the commonest condition, and there isn't such a high profit in making that. But that's something I'm going to ask the Marfan Trust also to try and help me lobby the companies to do, because that would be a big advantage to our patients. This is my dad, who I'm very proud of, who introduced me first to Marfan syndrome. He's also a cardiologist. There's an interview that Victoria's done with my father and myself, talking about how he inspired me to work with children with connective tissue disorders, and I'm trying to do my best to inspire my daughter Sophia, who's also very interested in this, and she's currently a medical student. So I think I'm going to stop there and see if there's any questions.
Thank you so much, Nitha. A few comments have flooded in. Great to do a CT scan when it's not an emergency, because then people know what to expect.
Exactly. And the main issue for the children with the CT scan, which is I'm sure the same issue for an adult, is having a cannula, because that's painful. It shouldn't be too painful. We do have for children a spray, which is a cooling spray which freezes. So what I try and do to children, and this is something as parents you could do, is I always say to them, like, I get their hand and I say, look, I haven't got anything at the moment, this is just my hand and this is what it's going to feel like, and I just push my nail in a little bit, because it's not like you feel nothing if you have an anesthetic cream like Emla or Amitop, or you have the freezing spray. You do still feel something, but it shouldn't be painful. I do also think we should offer that to adults as well. And now we're also getting better technology. We now have machines where we can put a light on the hand or do some kind of ultrasound so we can see the veins, and that makes it easier. The other hint I give to people is, if you're going to have a cannula, if you can, try and wash your hands with as hot water as you can manage, because that will make your veins stick up and make it easier and make it less likely that you're going to need a few pricks, because it is obviously awful having injections and cannulas.
That's a really good trick. Thank you so much, Nitha.
Thank you for asking me, and thank you everybody for listening.